Um, Thank you so much for joining, colleagues. It is my pleasure to welcome you to the final. This is it's quite surreal to say that actually it is the final WHO ECHO webinar for pediatrics and adolescents for the year. We've had a really good year. And for many of you who have joined us and stayed with us through the year, you will note that one of the most constant questions that we've had is on data and strategic information. So how do we get our data right? How do we get our numbers right for us to have quality pediatric and adolescent HIV programs? It is why I think it is absolutely apt to have a webinar that is titled Getting the Numbers Right: Strategic Information and Innovations for Pediatric and Adolescent HIV Programs. I remain, your colleague who's been with you, all through the year as well. My name is Wole Ameyan, and I am the adolescent HIV focal point at WHO headquarters here in Geneva. And together with my colleague Ivy Kasserie, who you know as well, we will be hoping to bring you a webinar that responds to the right questions on this topic. Now, before I start, I think it's important to go through a few housekeeping items, which starts from the next slide, and it is on interpretation. So we have the pleasure of our colleagues, Pata, who have collaborated with us to ensure that we have this webinar in 3 languages. So we have, of course, in English, but we have also in Portuguese and in French. So as always, if you want to listen in whichever of these 3 languages you prefer, simply click on the interpretation button and you will be able to listen in your preferred language. Next slide. Still on housekeeping, it is, as always, we are recording this session. Really, the reason is to ensure that we have a record of it and people can go back to the really useful, beneficial information that comes out of these WHO ECHO sessions. It's such a pleasure to have already over 200 people joined. I think, as always, we want to meet you. And in doing that, let's do what we always do, which is use the chat box to introduce ourselves. We keep it as simple as possible. So your name, organization, but also where in the world are you joining from? It would be great to meet you in the chat box. Thank you very much. Also, for any IT problems, please, all you need to do is type in ECHO IT into the chat box, and our colleagues, ever dependable from ECHO IT, will be able to hopefully resolve any IT problems. As part of the ground rules, for those who are on the call now, we want you to engage as much as possible. Indeed, the purpose of this webinars and this what has become really a series, really is for us to engage and to discuss. So please do that. There are 2 functions. If you want to give general comments, give your ideas and suggestions, please use the general chat function. So that's the chat box for general comments. But if you have any specific questions to the panelists or the presenters that you want answered, please ensure that you use the Q&A function, which is just right in the middle of your screen. Next slide, please. We give a certificate of attendance, which is really popular. We always get emails on these. So you will be able to get a certificate of attendance if you want it. All you need to do is fill in a short survey, which will be sent to you soon after the webinar. But I understand also that close to the end of the session, the survey link will be sent and you will be able to get your certificate of attendance. All the slides and the recording of this session will be shared by email for those who have registered. So hopefully looking forward to packaging all of this in a very nice way so that you can have these for your records and for your referral. A message to our dear presenters and speakers. Absolutely a pleasure to have you, spend your time and give us your expertise. Please let us keep to the time allotted for each speaker. But also for the sake of our interpreters, please, as much as possible, speak, pace yourself while speaking so that our interpreters can hear you speak very clearly and interpret appropriately. Next slide. On the next slide, it is, this gives a general objective of this brand, really. It's become a brand, the WHO Teleecho Sessions. And the reason why we, started this, a few years ago is for us to have this platform to exchange ideas, to learn, to inform, to discuss. It's the vibe of the sessions have changed over time. But I have to say you have kept, faith, and we have continued to use this platform as a really solid platform to share solutions and to trigger technical support and assistance. Next slide. On the next slide, I believe, is the objective of this webinar. Again, when I started, I mentioned how many questions we get on, on data and strategic information. So we have quite a few objectives, but the three core objectives for today, which I am sure we'll be able to accomplish, is first, we want to be able to share an overview of the WHO person-centered HIV strategic information guidelines. What recommendations are there. This comes from 2022, I believe. So we'll be able to share and give that overview. Secondly, we will be able to link this overview presentation to some very specific country case studies, and I'm really delighted that we have a couple of countries to share those. And then finally, we have a platform here to use those country discussions and the overview that we've given to discuss in a panel, but also as a group, as a global community, on current, but also potentially future directions for strategic information, particularly for children and adolescents. Next slide. I believe this is my final slide, and it is on the agenda. And what a brilliant agenda we have. I mean, you look at the array of speakers, you don't have any doubt that they will do justice to this topic. Without mentioning the names, because they will get their proper introduction later. Like I said, we will start with an overview of the WHO strategic information guidelines. After that, we'll go into country presentations and examples. Delighted, and so happy to have the Ghana experience and the Botswana experience being shared. The health facility, of course, is where most of it happens, right? But also in communities. So we have as well our colleagues from PATA, who will give us that perspective from on collecting quality data from health facilities. And then we have, of course, again, our colleague from UNAIDS, who will be sharing strategies for measuring impact with a focus on prevention of vertical transmission programs. Following that, we will have a very solid panel discussion moderated by our organizer, really, Ivy Kasirye. I mean, the names in there speak for itself, and then we go on and we wrap up. Okay, so let's get on to it. Cannot wait. I'm going to introduce the chair of the session, who's going to take us through the rest of today. And it is my pleasure to introduce, but also to hand over to my colleague from WHO Malawi, from WHO Uganda, I beg your pardon, Dr. Kagwa Mugaga. So over to you, Mugaga, and take it away.
Okay, thank you, Wally, for the warm introduction, and I welcome all colleagues that have logged on to today's sessions. As introduced, I am Kagwa Mugaga from WHO Uganda Country Office, and I would like to welcome all the speakers that are ready. Without wasting much time, allow me to introduce our first presenter, Heward Haile Selassie. Heward Haile Selassie is a consultant working with the Strategic Information Unit of the HIV, Hepatitis, and STI Department at our WHO headquarters. Now, I welcome you, Heward, to make our first presentation. Thank you very much.
Thank you, Mugaga. Great to see you, and good afternoon, colleagues. So it's a pleasure to join you today. So I'll be presenting the WHO HIV Strategic Information Recommendations and Guidance for Monitoring HIV Testing and Treatment in Children and Adolescents. So next slide, please. So by way of introduction, this slide highlights the progress that we've seen in HIV testing and treatment and care over the years. And you can see in the figure on the right the progress towards reaching the HIV testing and treatment targets in 2023, both globally and by region. So in 2023, about 85% of all people living with HIV globally were aware of their status, 77% were on treatment, and 72% were virally suppressed. And in sub-Saharan Africa, we see even higher coverage rates, with 90% of people living with HIV aware of their status, 82% on treatment, and 76% virally suppressed. Next slide. We know, however, the situation for children and adolescents is quite different, with progress towards the targets for testing and treatment lagging significantly behind. And that's what's shown here in both figures on the slide. So you can see the trends in ART coverage for children aged 0 to 14 years in the figure on the left. And while it has increased over time, it remains suboptimal at only 57% in 2023. Similarly, when we look at the overall testing and treatment care cascade for children in 2023, on the figure on the right there, we see limited progress, with only 66% of children living with HIV aware of their status, 57% on treatment, and 48% virally suppressed. Likewise, for adolescents, only 65% of the estimated 1.55 million adolescents aged 10 to 19 years living with HIV globally were receiving treatment in 2023, which is much lower than the coverage rates for the HIV care cascade you can see for adults that's shown in the blue box on the slide. And so to address these gaps in the HIV care cascade for children and adolescents, we need better quality data, and we need to really strengthen the use of data to really tailor service delivery to the specific needs of these populations. We acknowledge that there are some gaps in the pediatric and adolescent HIV data, which is why we welcome this webinar and the opportunity to discuss this today. Next slide. So to improve programmatic impact and HIV service delivery, WHO launched its consolidated HIV strategic information guidelines in 2022 to strengthen person-centered monitoring and data use. The guidelines include 22 key data recommendations that really focus on individual level data that come from service delivery sites, with a focus on integration of services and routinizing the use of data. The use of a minimum data set that captures key events in an individual's interaction with the health system is recommended. And based on this, there are 80 priority indicators for HIV program monitoring and management for HIV prevention, testing, treatment and care, and comorbidities recommended by WHO, of which 25 are designated as core. So in other words, really important for programs to monitor at a minimum. Next slide. So there are 5 key recommendations included in the WHO Strategic Information Guidelines for monitoring HIV testing and treatment, which apply to all age groups, including children and adolescents. So the first recommendation is a new recommendation that's focused on testing, and it's to promote both the analysis and the use of routinely collected testing data, and to use that to really target and optimize testing services to reach the groups and the populations with the largest proportion of people who are unaware of their HIV status, including children and adolescents, to support early HIV diagnosis. The second recommendation, again, is focused on data use, this time using patient data to be able to continuously assess treatment interruption, and then using that information to improve re-engagement and retention in care. The third recommendation is a new recommendation on monitoring differentiated service delivery, and it's to integrate and strengthen both the collection and the reporting of DSD within HIV patient monitoring systems, both in facilities and in community sites, with the goal of improving treatment outcomes and programmatic efficiency. The fourth recommendation is an important recommendation that's focused on data quality and use, and it's to include routinely scheduled data quality assessments and to really integrate these within long-term data quality improvement strategies, which include a range of activities, including but not limited to data quality assessments, to really strengthen the use of data and improve treatment outcomes. And the fifth and final recommendation is a new recommendation on using drug stock data at all levels to inform the management, the dispensement, the procurement and logistics to reduce drug wastage at stockouts at all levels. Next slide, please. So as I mentioned, a minimum data set is recommended by WHO to help countries prioritize the key data to collect for HIV testing and treatment. And this is available as Annex A in the guidelines, and the key sections are shown here. I won't go through the details in the interest of time, but just to highlight that this is a resource that countries can use, irrespective of their data systems or their patient monitoring tools that they're using, to help them define and collect the key data for HIV patient monitoring, including the services provided to children and adolescents, to be able to monitor and report on the recommended priority HIV testing and treatment and care indicators, which are on the next slide. So next, please. So this slide summarizes the priority indicators that are recommended by WHO for HIV testing and treatment and care. And notably, since the cascade of care for children and adolescents living with HIV is similar to that for adults in terms of diagnosis, most of the indicators for children and adolescents are exactly identical to those for adults, with the exception of a few population-specific indicators on vertical transmission of HIV. So I'm going to focus on the indicators for testing and treatment, which are highlighted in the red box. But just to alert you that there are also priority indicators for TB-HIV, for vertical transmission, as well as for HIV prevention, many of which are relevant to children and adolescents. So again, since we're limited on time, I won't present the indicators in detail, but just to say that there are 6 priority indicators that are recommended for HIV testing that are shown in the yellow box in the top left-hand corner of the slide. And you can see the ones with the blue circles are designated as core indicators, so really important for programs to monitor at a minimum. So there are 6 priority indicators for testing, of which the first 95 target on people aware of their status, an indicator measuring the number of individuals testing positive for HIV, and an indicator on linkage to ART are designated as core indicators, linkage to ART being the proportion of people who are newly diagnosed that start treatment. For HIV treatment and care, there are 9 priority indicators, of which 4 are designated as core, including the second 95 target on people on treatment, which is both the number and the coverage, an indicator on total attrition from ART, which measures retention in care and losses from the treatment program, viral suppression, and importantly, late ART initiation, which is the proportion of people who start treatment with a CD4 count of less than 200. I also want to highlight that there are 5 priority new indicators for monitoring differentiated service delivery for HIV treatment, including a core indicator on multi-month ARV dispensing, 2 indicators on uptake and coverage of DSD-ART models for all populations, including children and adolescents, to assess whether people who are eligible for those services are actually receiving them, and then the 2 indicators that measure the treatment outcomes of retention in care and viral load suppression among people receiving DSD-ART. So those are the testing and treatment indicators very briefly, but I refer you to Chapter 3 of the guidelines for the indicator definitions and details. Next slide. The guidelines also include some specific monitoring considerations for testing and treatment for children and adolescents. So the guidelines recommend age disaggregations in 5-year intervals for all the priority HIV testing and treatment and care indicators I just presented for children and adolescents, and that's shown in the red box on the slide. And this is really to help identify the service delivery gaps, be able to improve the quality of care for children and adolescents. And finer age disaggregation is now more viable in many settings, including resource-limited settings, because of the expansion of digital platforms such as electronic medical records. However, for facilities using paper-based reporting, we recognize that reporting on these disaggregations may be challenging. The use of unique identifiers, which are standardized anonymous alphanumeric codes, is also recommended by WHO to strengthen the ability of programs to track and monitor clients, including children and adolescents, across multiple service delivery areas and different health facilities and sites, and over time to improve integrated patient care. Some of the key elements recommended to be monitored in children living with HIV in the guidelines are shown on the slide in the yellow box, and they include age at diagnosis and ART initiation to understand the issues that are driving late treatment initiation in children, as well as retention in care and the receipt of viral load testing, and importantly, viral load suppression, amongst others. Similarly, for adolescents, it's important to track adherence and viral load suppression, as well as the receipt of psychosocial interventions, including adherence support, to really strengthen service delivery for this population. Next slide. Next slide. Lastly, I just want to touch on data quality and the WHO guidance in this area and some of the tools that have been developed. So we know that data quality is a huge challenge for HIV programs in general, but also for children and adolescent programming. So WHO recommends that countries develop strategies for data quality improvement and use that link data quality assessments with the implementation and the follow-up of remedial actions to address the underlying issues and contribute to the data quality issues that we see. So WHO and partners, including UNAIDS, PEPFAR, and Global Fund, have developed joint harmonized tools for data quality assessment for both HIV treatment and viral load testing data, designed for service delivery sites with age disaggregations, including the tools for children and adolescents that facilities can adapt and use to verify the data for these populations. So these are available on the WHO website, and the links are here, and they're helpful tools for improving data quality at the facility level. Next slide. So in summary, the WHO HIV Strategic Information Guidelines really emphasize person-centered monitoring and the use of data to improve service delivery. WHO recommends age disaggregation by 5-year age bands for all the priority testing and treatment and care indicators for children and adolescents. And this is really recognizing that these populations may experience unique barriers to testing, to care services, as well as retention and adherence in care. And so based on their age, and so finer age disaggregations can reveal where those gaps are and provide essential information to improve service delivery. Some of the specific challenges for monitoring HIV services in children and adolescents include the fact that they may be lost to follow-up before their HIV status is determined, as well as issues with tracking them across multiple service delivery points and health facilities from diagnosis through to referral. And lastly, improving data quality and strengthening data use is critical for tailoring services to children and adolescents and achieving the national and global targets for these populations. Next slide. Okay, so that was my last slide. These are my acknowledgements, and thank you, and happy to take questions. Back to you, Mugaga.
Okay, thank you very much, Heward, for the comprehensive presentation that you have made. Now we go direct into the country studies, and allow me to introduce our next presenter, Dr. Stephen I.C. Addo, the Program Manager of the National HIV and AIDS Control Program, Ghana Health Service. Over to you, Dr. Addo, to give us Ghana's case study.
Thank you very much, Dr. Mugaga. Thank you, distinguished participants. I bring you greetings. So good morning, good afternoon, and maybe good evening to those that is relevant. So how would you get the numbers right? Strategic information innovations for pediatric adolescent HIV programs. Can you move to the next slide for me? So this will be the outline of my presentation, a brief background of the country epidemiology, and then we'll zoom in on specific examples because of the children. That's why we are here. Next slide. So Ghana is in the West Africa, bordered by the Gulf of Guinea, Burkina Faso, Cote d'Ivoire, and Togo. There are 16 regions, and the population is estimated at 34 million, and 38% of them are children less than 14. Almost 57% reside in urban areas, 66% life expectancy, and a GDP per capita of 2,238. We have the triple burden of NCDs, communicable diseases, and road traffic accidents. Next slide. So this is a situation, a snapshot of our epidemic. An estimated 334,000 people are living with HIV. And as you can see, majority are female, 65%, and the children constitute about 5% of that. So please take note of the figures for the children. As at the end of 2023, we estimated that 17,774 new infections occurred, and about 10% of that were children, 1,698. 12,500 approximately of AIDS deaths, and 11% were children. Now, when it comes to the 95 indicators, Ghana is at 65, 69, and 89. For the children, it's 37, 83, and 89 for the children. And ART coverage using the estimated population of people living with HIV is 46%. It's 30% in the children. And PMTST coverage is 90%. So we have a very high PMTST coverage. The adult prevalence is 1.53, and prevalence mother-to-child transmission is 5% at 6 weeks and 13% at 18 months. Next slide. Next slide. So first of all, to be able to report important and accurate or relevant data, you need to have the tools. So in line with the WHO guidelines, our routine HIV testing tools has 5-year band age disaggregation, as you can see displayed, from 0 to 4, 5 to 9, and so on and so forth, up to the adults. But for the children, you can see that it's well disaggregated for the indicators of testing, and then children into care. Next slide. And it's also further disaggregated by gender. So based on this, we have routine data review meetings that enable us to look at the data in a disaggregated form by age among the children. So for instance, when I'm using some examples, like for the quarter 2, 2024, HIV testing yield in children for males was 3% and 2% for female. For children 0 to 4, 5 to 9, as you can see, is 3%, and 10 to 14, 2% for both. And when you talk about different subpopulations, you can see that we've disaggregated it in the children, the female, young people, males, and all that. All this is to help us to be able to isolate and to be able to focus on specific subpopulation, particularly the children who are of interest this afternoon. Next slide. So early infant diagnosis is very key. And the data we have, as an example, to illustrate what I'm talking about, you can see is disaggregated from 0 to 6 weeks, 6 to 12 weeks, 12 weeks less than 9, and 9 months to 13 months. So as you can see, the exposed infants identified is 3,000, and exposed tested is 1,795, and so the coverage is 48. Now, we are noticing something as far as the infants identified is concerned. It looks like we identify fewer children based on our database. But if you begin to look at the differences from 6 to 12, then you see some differences in the coverage also. Next slide. So with respect to the use of data for decision and all that, we noticed a drop in the number of children on ART. We wouldn't have noticed it if we hadn't disaggregated the data, comparing the adults versus the children. And we noticed that by mid-June, the numbers for children dropped, whereas there was an increase for all other population. So that actually formed the basis of certain discussions of what we can do to achieve improvements as far as the children are concerned. I have to indicate that some of these data have contributed to the development of an acceleration plan, which I'll talk about later. Next slide. So for viral load, in 2021, data collect, we did certain things. We put in some mechanisms to improve data collection as far as viral load monitoring was concerned. In 2021, we did not have any data disaggregation. And then we embarked on a pilot with the support of UNAIDS to do some data disaggregation. And that revealed huge disparities. So we noticed that the children had a suppression rate of 62 compared to adults of 89%. But if you look at just the population prior to it, we will say that 88% had suppression. But it was when we disaggregated and we noticed that the children have a lesser, suppression rate. Next slide. So now data tools that enable a disaggregation of viral load data have been introduced, and we routinely review the periodic data, pediatric data on viral load. We have also deployed point of care using GeneXpect for viral load testing and early infant diagnosis. We have trained pediatric service providers in pediatric care, and we have introduced dolutegravir. This evening, we'll be having a meeting to review early findings from the study that we undertaken, resistance to dolutegravir amongst the children. And so you can see the gap between viral suppression for children and adults. It used to be, if you look at the Volta region data, it was less. In the national data as of September 2024, is 71 compared to 89% in the adults. So next slide. Ladies and gentlemen, in conclusion, I have to state first of all that our pediatric performance has been masked in the past by very large numbers of adults. And I want to take the opportunity to highlight some of the challenges. Because of that, it was not so easy to effectively prioritize for the children. And despite the fact that we knew that the children had the challenge and there was a gap, it was very difficult because the data was not disaggregated to reflect their true state. But disaggregation of data has proved very critical to guide our way forward. Because of this, we have developed an acceleration plan and a guidance document, building on the previous strategy plan for children that says that we should disaggregate data. It was not so easy because updating the tools at any point in time requires that we have to retrain the people. But we took the bold step and we've been able to do that. And now the data is showing, even though we don't have full coverage or completeness, at least the sites that we are able to pick data, we can be able to determine that there's a gap relative to the adults. And to a very large extent, this has been supported by specific data reviews and discussion with stakeholders. Now we are able to use the data to guide our community adolescent treatment supporters program. We are able to use this data to also support the work of mental mothers, because we are able to tell, what is happening with respect to the children. And I need to be able to add that we've even gone to the step of doing the STAGBA analysis, looking at mother-to-child transmission. We have deployed a mother-baby audit tool. So based on the ability of our tools now to identify babies who are positive for exposed babies, we undertake an audit like the maternal mortality audit. And we've even been able to support some master students to be able to do this analysis. And we continue to improve this database, which will help us. So I want to thank you. On next slide, I want to thank the WHO and all our partners, the UNICEF, the UNFP, all the members in the joint UN team on AIDS, the Global Fund to fight AIDS, TB, and malaria, PEPFAR, CDC, USAID, and all our civil society organizations and other stakeholders, private sector, our hardworking service providers who are doing all the hard work, and everybody who has contributed to this. I want to thank you all for your audience. And now I remain available for any questions. Thank you very much.
Thank you very much, Dr. Ado, for that very candid sharing. And I think you have highlighted the very important points of the presence of tools and the need for disaggregated data to avoid masking certain service disparities. Allow me now to introduce our next speaker, Dr. John Farirai from Botswana. He is the Associate Clinical Director of Beira, Botswana. Dr. John Farirai, you are welcome to share with us the Botswana experience. Thank you.
Thank you. Thank you very much, Dr. Kagwa, for the introduction, and good morning, good afternoon, good evening to everyone who's in attendance. So I will present on the enrollment of children and adolescents living with HIV on ART, the data-driven approach. Next slide, thank you. So just to introduce what Botswana Bela does, Botswana Bela is actually a partnership between the government of Botswana, Bela College of Medicine, Texas Children's Hospital in the US. So through this partnership, we assist the government in providing HIV services, oncology services to the public at free of charge, with no user fees. So on HIV, we do provide treatment, of course. Besides treatment services, we also do provide HIV testing, counseling, also HIV prevention. One of the main backbones in terms of support is actually psychosocial programs, which include teen clubs, young adult groups, and also young mother support groups and so forth. Thank you. Next slide. So currently we are based in Gaborone. We actually have about 2,400 patients on treatment. As you can see, under fives, about 55, which is very low proportion due to the effective prevention to mother transmission program in Botswana. Loss to follow-up is also below 1%. We've got good survival rates. On our cohort of 0 to 19 patients, viral suppression rates is around 92%. We also provide support to 14 outreach sites around the country. so mentorship, training, and also clinical advice. Next slide, please. So just as where is Botswana? Botswana is in Southern Africa with a population of 2.3 million. Because we cannot compete with Ghana on that one. Prevalence for 15 to 49 stands at 16%. That's UNAIDS estimates, which brings to 360,000 adults and children living with HIV. Incidence around 3 per 1,000 amongst 15 to 49. Vertical transmission rate, that is mother to child transmission, it's at 1.17%. Coverage for above 15 years stands at 95%. Next slide, please. A recent Botswana AIDS Impact Survey report, which was released in 2023, showed that the annual incidence was around 0.2% with a prevalence of 20.8%. Prevalence amongst children, it's around 0.8%, which puts it at an estimated 5,600 children living with HIV. In terms of prevalence for viral suppression amongst adults, so this is all adults, both on ART and those who are not on ART, it's around 91%. As for the 95 targets, the country recently celebrated the achievement of 95, 98, and 98. Next slide. So this is just a slide showing the different age groups and the viral suppression. As we have already said, in the adult population, we achieved 98% viral suppression for those on ART. For children, adolescents, it's around 95%. And for less than 5 years, it's around between 80 and 89%. Next slide. In terms of PMTC data, also the country achieved a milestone, being recognized probably one of the first countries, if not the first country in a high HIV burden country to achieve this silver tier certification for prevention of mother to child transmission. So we actually have fewer than 500 cases per 100,000 deliveries, less than 5% vertical transmission rate. More than 90% of pregnant women are on antenatal care, and also more than 90% of HIV positive pregnant women are actually on ARV therapy. Also, according to UNAIDS, we actually have less than 100 new infections per year out of the 9,600 HIV-exposed babies which are seen annually in the country, which gives actually from the EMTC program estimates the mother-to-child transmission rates, it's at around 0.59%. In terms of testing at 6 weeks, that is the DNA PCR, we stand at 86% coverage, and also the 18 months rapid test is at 82% coverage. Next slide. So amongst children, so we actually showing statistics from UNAIDS and the AIDS survey, which I talked about in the previous slide. So from the estimate, we are seeing around 5,100 children. However, from the estimate, they actually say our coverage is not optimal at 66% coverage. That is for 0 to 14 years. Of course, the prevalence we've already shared at 0.8%. Something we can also share, unlike adults who have achieved 98% viral suppression, we find out that young people are actually at 77%. So that's also another group to look out for. Next slide. Next slide, please. So you can go back one slide, please. I think we've skipped one. Yeah, thank you. So in terms of 95 targets for children, we recently had a Botswana AIDS Impact Survey, which is really a household survey. And this is the one which actually informed us that the country had achieved its 95 targets. However, in this survey, data for children has been missing simply because the sample size of children, which the survey actually found was too low to actually come up with estimates. So really, we are not really, in a way, particularly the first 295s in terms of what is the coverage of the first 295s for children. However, from program data, we actually find that currently there are 3,165 children on ART and 92% of them are suppressed. So the question is, when you compare the estimate of, which is actually from a modeling, which is 5,100, and you look at the current on treatment, you actually think, okay, are there any children we are lost to follow in terms of the HIV cascade, maybe at the testing stage or maybe at the linkage to care? Next slide. So this is what we are at. So using those estimates, you see that's 5,070, which is around 5,100. And we actually saying, using that estimate, only 62% are actually on ART care. And then of those on ART, 92 are suppressed. Next slide. So the question we had, okay, we know in Botswana that most of our mothers are pregnant mothers actually linked or are in antenatal care. Those who are HIV positive, more than 90% of them are actually on care. So we presume that most of these babies should be actually be in facilities at birth. So the issue, what we wanted to do now is to use those records and try to investigate whether there could be possible loss to follow from the time of delivery to 6 weeks and so forth. Next slide. So with that thought, we actually came with support from USAID. We did what we call a testing outcomes of HIV-exposed infants in Botswana. So what we did is that we actually went into the registers for the 3 major hospitals in Botswana, which is Princess Marina, which is in Gaborone, Nyangabo, which is in the 2nd largest city, and then Lesola Tebe, which is actually in one of the major populated areas. So we went through the registers, randomly selected 454 infant records. So these were actually records for infants who were HIV exposed, so born from mothers who were HIV positive. Next slide. Of course, there were some young mothers at delivery, estimated at around 14% were young mothers, and then 20 to 35 as well, majority of the mothers were 53%, and 33% of the mothers were above 35 years. Next slide. In terms of enrollment into ANC, we can see from this slide that majority actually enrolled in the 1st trimester, and then most of them also followed in the 2nd trimester. There's a very small number actually presented late, either at the 3rd trimester or at delivery. Next slide. Most mode of delivery was actually vaginal delivery. Next slide. In terms of infant feeding, majority were formula fed, which is 71%. So these are all HIV-exposed babies. Just to give a perspective, so in Botswana, all HIV-exposed babies can, if the mother chooses to formula feed, the government provides formula milk free of charge. So maybe that's why it may be different with other countries where it might not be free. Next slide. Infant prophylaxis for this cohort was very high. Remember, our denominator is 454, so more than 90% of the clients actually received either cotrimoxazole or prophylaxis, and also single-dose nevirapine and AZT prophylaxis, which was used at that time. So this cohort is actually from 2016. Thank you. Next slide. Next slide, please. Turnaround times for DNA PCR. This is the DNA PCR, which is done at 6 weeks. We're actually relatively good, with more receiving the results within 1 month. Our gold standard is actually to receive them in 2 weeks, but as you can see, they most received the results on time. Next slide. So out of the 454, we realized that those who actually tested were around 437. Only 16 clients out of the 454 never actually tested for HIV. So from birth until the time we actually interacted with the client, only 16 had never tested. Next slide. So this is the overall results for all these children. We can see that only 7 out of the 454, which is 1.5%, actually had a positive result. Next slide. And we did have an opportunity to test those 16 children with no test results, and all of them tested HIV negative. Next slide. This is actually the characteristics of those babies who were positive. Out of the 7, around 3 were actually started treatment less than 6 months of age, and the other ones were started late, probably late diagnosis. Next slide. So actually from this analysis which we did, we actually found that there is actually relatively low loss to follow amongst HIV exposed babies, and also low rates of mother-to-child transmission, also rare deaths from this cohort. So what we can actually also conclude is that utilization and analysis of program data is vital in monitoring access and coverage across the HIV treatment cascade. Model estimates from our own views sometimes can be limited due to generalized assumptions, which might not be applicable in all contexts. So this is why what we are trying to say. We have, according to UNA, is that coverage is very low, but when we went to investigate, we didn't see such evidence. However, we will continue to work with all these partners to see where there might be issues, whether is it because we are missing these babies, or is because some of the model estimates may not be accurate in our settings. And of course, data-driven programming needs to be scaled up to ensure children and adolescents living with HIV are diagnosed, linked, and retained in care. Next slide. Thank you so much. Thank you all for your attention. Next slide. So just to thank all our partners we are working with, Ministry of Health, WHO, and all other partners we are working with in terms of improving the life of children. Thank you very much.
Thank you very much, Dr. John Farirai, for that good presentation. I can see that there is work going on, being that you are already in the pre-elimination cascade. Thank you for sharing that Botswana experience. Allow me now to go into the next presentation and introduce our next presenter, who is Dr. Vanessa Fozayo. Dr. Vanessa Fozayo is a health enthusiast with over 4 years of experience in the field, with keen interest on HIV and AIDS. She currently works as Cameroon country representative for PATA, which is Pediatric Adolescent Treatment Africa. Dr. Fozayo, you are welcome.
Thank you very much, Mugaga. I will flash my camera for a bit and I will put it off because of network issues. So thank you. So as we all know, PATA is a network of frontline healthcare providers who believe in doing it now, doing it together, and doing it right. And so I'm here to give the perspective of the frontline healthcare providers. What are the challenges they face and what we can do? Slide, please. So we're going to follow the outline. Can we move to the next slide? Thank you. So I'm going to begin my presentation with a claimer. You know, people always start by giving disclaimers, but I'm giving a claimer, and the claimer is that data is the senses. Of course, it has a smell, it has a taste, it has a view, and it has a feel. And for sure, data is always speaking. The question is, are you listening? So if we are saying that data is of the senses, then data must make sense. So it is my hope that at the end of this presentation, we are all going to agree that data should make sense. And who should it make sense to? To those who generate it and to those who use it. To those who generate it to know how and when to use it. Slide, please. So when we look in the fashion of an introduction, we know that it's critical for us to collect and report data to improve on the health outcomes of our patients. So as healthcare providers, or frontline healthcare providers, there are a range of challenges that we can face. And of course, a lot of barriers too that can happen for us to get efficient data and to be effective in data collection. So the aim of this presentation will be to explore ways by which we can improve on data collection systems, while we are also highlighting practical solutions that should empower healthcare providers like you and me from all levels, be it at the facility, be it at the managerial level, whatever level, to know how and when to use data. Slide, please. So what is our role? Of course, as clinicians, we are mostly the first people to come in contact with data. And we collect data through many different routes. It can be by patient records. It can be because we are doing observations. It can be even from the interventions that we are doing for patients. And of course, when data is collected, it should be entered, it should be analyzed, and it should be reported. Now, the big question is, these people who are supposed to do all of this, do they understand why it's important? When somebody does not understand why it's important, that's why we see cases where data was corrected inadequately. So if the process goes wrong from the start, we should be sure that what we get at the end is not going to be good. You know, in local parlance, they say rubbish in, rubbish out. So if you put in the wrong thing, then you get the wrong thing. And again, I'm going to insist that if the service providers do not understand, then they are not going to do the right thing. So we have to ensure accurate and effective data collection so that we can strengthen the health system and to improve patient care. Initially, we heard about patient-centered care. So we need to do everything to improve on patient care. Slide, please. So what are some of the challenges that we face? Incomplete or inconsistent data. Of course, if data is not complete, you cannot make sense of what that data is telling you. I think if we look from the case study that Ghana has shared and the case study Botswana has shared, it's clear that if we are looking at data in fragments, we are not able to make sense out of it. There are also issues with time constraints. A lot of the times, the person who is supposed to collect the data is the same person who is supposed to report the data, is the same person who has like 100 other documents to fill. And so the patient is also saying, I'm tired, I have to go home. Now you see that there is that time constraint for the person to enter that data adequately. We also have the issue of heavy workloads. You know, we are in settings where, especially for low and middle income countries, the personnel are not very available. So for the few people that are available, they have a lot of things to do. Or we have instances where some people over-specialize in particular aspects. And so all the workloads fall on their heads and it becomes so difficult for them to do the work with fidelity. We also have the issue of inadequate training or support. You have somebody you're asking to give you data, but this person does not even understand what that data means. He does not have any support whatsoever. You know, we have been told that many times the supervisors play the role of strictly supervisors and not mentors. And so if you're expecting something from somebody and that person cannot give it to you, it becomes a problem. And of course, there's a problem of too many tools and duplicate data. It is clear that most of the data we have intersect at certain points. We need to find where these data intersect and we gather there. Because if we find where our data is cross-cutting and where it intersects, then we can propose solutions. Some of the opportunities we have is that we can simplify the tools that we have and our guidelines to permit everybody interact with those tools. We can make sure that we are sharing activities among ourselves, not carrying all the workload on yourself. Meanwhile, there are other people that can assist you. We should continue mentoring and supporting the healthcare providers whom we expect to give us this good data quality. And lastly, but not the least, we should be able to have a consolidated data system or unified platforms that will ease the use of data. Slide, please. So in terms of innovation and what are practical solutions, we have heard about mobile technologies or digital tools. I think in certain places, you will find that community health workers have simple applications on their phones or on tablets, which they can use to collect data in real time, which goes a long way to minimize errors and allows for real-time data reporting. We also need to have training and capacity building. If we're able to continuously train those that are going to generate the data and enter the data to understand the why behind the data collection, then we are going to be solving a big problem as to how the data comes in and how the data is used at the end.
Vanessa, have we lost you?
Can you hear me?
Okay, you are back. Thank you.
Thank you. Sorry, it gets real. So I was saying that the next thing would be to have automated reporting systems whereby we can have our reports go out at the same time when we are generating them. This saves time for the healthcare providers and reduces the risk of errors. We should have mechanisms for quality checks, which can notify providers that there is something wrong with the data you're sending out. There is a system we use in Cameroon called Data. And most of the time when the service provider is entering the data, there are quality checks that pops up. For example, if I'm entering data for a pregnant woman and at the level of gender, I placed male, the quality check is going to pop up to remind me that you are working with a woman and not a man. Or if you are talking about ANC, it should be a woman and not a man. So quality checks like that can help service providers fine-tune their data entry. Of course, community health worker empowerment. A lot of the data we have is generated at the level of the community. So if they have tools that are friendly, like tools that are solar charged, that can permit them to work freely in the community, then we can be sure to collect data in real time on the field. Slide, please. So in terms of, still in terms of innovation, I did mention that service providers should understand why they are collecting data. And as a way to help service providers, this is just a simple algorithm that should help us to understand how to use data. You start by conducting a gap analysis, which should orientate you to where the gaps are. And of course, you can propose a quality improvement project that is there to address the majority of the gaps that you have. Now, when you understand the problem that you have, you begin to analyze the root causes of the problem. And from the root causes, you can develop and prioritize solutions that can, at the end of the day, provide the feedback that you want. And of course, there is no way that you can get solutions without the feedback. So you should be able to monitor and track the progress that has been made so far. Slide, please. So I'll just give this quick example, which was in terms of viral load uptake and coverage. We all know that viral load uptake is just the number of, in this case, I'm using children, which is just the number of children who were eligible for viral loads, and the viral load was done irrespective of if the results came back. While viral load coverage is those children that were eligible, viral load was collected, but results had not returned. So in this example, in a particular district in Cameroon, the viral load uptake of the facility of the district was at 70%, yet their suppression rate was at 91%. So this facility was contented, like, we are doing good, but each time they'll present this data in a data review, they'll be told, no, there's still a gap. So they didn't understand what this gap was until a mentor came to site and sat down with them and explained to them what it meant to have this uptake and this. And the gaps they identified were the fact that most of the children were school going, and so it is the caregivers who kept coming for their drugs. So the only children they saw and had interactions with were the children that were actually collected for viral load. So what they did was to organize holiday mass viral collections. And from there, they were able to improve the uptake to 90%. But now they realized that the suppression rate dropped to 86%. now they began to understand why it was important for them to improve on the uptake and not just focus on the suppression rate. With that, now they were able to see that most of the children that drugs were sent to by caregivers, the adherence was not, there was no real way to really assess the adherence. So this helped them to restructure how they were doing their DSD models of dispensation to ensure that they were adequately providing adherence support even to the children who were not coming physically to the facility. Slide, please. So, for a healthcare provider's experience with data, we need the feedback. You need to engage us with data-driven insight. If we keep collecting data and at the end of the day, we don't understand how this data is impacting the work we are doing, it becomes difficult. These feedback sessions could be in a form of data reviews, which I heard Dr. Ferrari mentioned earlier. If we have data review, you give a platform for people to understand what their data is and ask questions relating to their data, we can improve on the outcomes that we are having. Slide, please. Slide, please. Sorry, the slide. Okay, I'm not sure what's wrong with the slide, but also just to mention that we need to be able to utilize data for clinical decision making, as well as real-time feedback. If we're able to do that, it's going to improve on the care that we provide to set patients in a patient-centric manner. Of course, the supervisors have a big role to play in terms of mentorship and on-the-job support, in terms of data review platforms, and in terms of data quality indicators. We should not just focus on the clinical or the technical support, but we should look at how they are generating and using data. Slide, please. And to conclude, we need a collective approach to improve on data quality. It's not just solely the responsibility of the health worker, but it requires a collaborative effort involving all supervisors, data managers, healthcare providers, is to simplify data collection, train them on how to collect and use data, feedback and support for the service providers, and of course, ownership of data quality for service providers. And looking forward, we have to continue with the innovation along with understanding of the challenges that healthcare providers face that will help us lead to more efficient and effective data collection and ultimately improving the quality of care that we provide to patients. So thank you all very much for listening to me. And I'm thanking the PATA team and I thank the frontline healthcare providers for all we do to provide the data that is used for decision making. Thank you.
Excellent, excellent, Dr. Vanessa. Thank you very much for a very well presented experience from Cameroon, PATA Cameroon. Allow me now to introduce the last speaker of this session, Anna Yakusik from UNAIDS. Anna Yakusik works with the Data for Impact Department at the Joint United Nations Program on HIV and AIDS, UNAIDS. Over to you, Anna. Thank you.
Thank you, Dr. Kagwa. Good morning, good afternoon, everybody. Today, I will be presenting some strategies for measuring impact on the example of the vertical transmission programs. And I've selected this background of the bridge, just showing how important it is to build bridges between data gaps to have a more comprehensive information about HIV and where we are in terms of healthcare outcomes in women, in adolescent girls, in adolescents in general, and definitely in children. Kindly, next slide, please. So just before we begin, I would like to say that it's an enormous honor to present on behalf of country teams and UNAIDS who produce the data and across our collaborating partners who also support in terms of methodologies and how the health systems and also data systems need to be advanced and elevated. And also just to also point out that behind the estimates, population level estimates, there's a reference group, the scientific reference group, that also advises on the model improvements, and many partners are involved into this work, as well as we have a separate multi-stakeholder subgroup that focuses specifically on pediatric estimates. And I would like to acknowledge their contributions in ongoing improvements of the model, the data, population level estimates, and definitely the partners across the Global Alliance and beyond, and our technical partners, Avenir Health, who maintains the spectrum model to estimate HIV at the population level. Kindly, next slide, please. So just to, I think, yeah, that's the one. Thanks. Just to provide you with a bit of a background, and also based on the presentations as we've seen from Botswana and Cameroon and Ghana, the stark reality that we see from the estimates at the population level is that too many children are still contracting HIV each year. And this underscores the urgent need for more effective vertical transmission programs, but also on our end, technically, are we measuring the impact of these programs right? And what needs to be done to improve those estimates going forward? Next slide, please. So in this presentation, I will touch base on several approaches that we use at the country level, but also at the global level, to triangulate the data across those approaches to get the data right. So given all the limitations that I will also cover. So to address the challenge of measuring the healthcare outcomes properly, we utilize three key approaches. The first one is the population-based models, such as Spectrum. Many of you have experience working with this model. Then there's another approach that is nationally representative studies or surveys that's been also mentioned by some country presenters, and also the foundation, as I would say, the routine program data and the requirements towards the routine program data as outlined by WHO guidance. I'll also touch base on those and the presentation that Hewat made in the beginning of this session. So the models, such as Spectrum, they provide population level estimates, offering a broad overview and capturing the entire transmission period for vertical transmission, for example. So it captures women who are accessing antenatal care, those who are not accessing antenatal care for whatever reasons. And often this includes marginalized populations or key populations at higher risk of HIV. This allows to compare the estimates across countries and have the baseline across countries to see where the countries are in terms of the targets or overall in their progress over time. This can help clarify the impact of also different interventions that are being rolled out at the national or subnational levels. However, the models as a limitation, they do rely on assumptions and data from various sources, including program level data, making the accuracy depend on the quality of those sources and input data that informs the population level model. So the models may or may not fully reflect the distinctions of individual country programs. And this is something that is behind the scenes being validated extensively by so many partners, country teams, and scientists. So the next slide, please. Population-based surveys. So this slide speaks to special studies that offer invaluable insights into the impact of, for example, vertical transmission programs, or in measuring the outcomes of HIV programs and healthcare outcomes, including prevalence of incidence maternal infections. However, they can be quite expensive. So they are nationally representative. Similarly to how the models are, they are nationally representative. So they speak to the entire population at the country level. The surveys offer very strong evidence base, and the only downside of those studies the downside is that the surveys can be quite expensive and time consuming. So to wait for the results of the studies sometimes can take several years. However, good news is that in high prevalence settings across African countries, we often do have such studies. And we do triangulate the estimates against the results of those studies to be able to understand where if the model projects in alignment with the survey results or not. So that's one of the validation strategies that we do have, and we apply consistently across the countries where those surveys exist. Next slide, please. So the routine program data, and this is something that has been mentioned so many times. This is the foundation. Routine program data provides the incredibly valuable information for program monitoring and improvement of programs. However, it has also limitations. So it's limited by its coverage and might not fully capture all transmission scenarios or accurately represent the true population level measurements, such as vertical transmission rates. And so the program data can provide the data that is just captured by healthcare systems. So if, let's say, a pregnant woman or a woman postpartum is not a part of the health services postnatally, the data from this mother or breastfeeding woman, and we do see, especially across Africa, that the duration of breastfeeding is quite prolonged across African countries. So if those women are not captured by service provision as well as by the data systems, we will not be able to see this person within our data record. So that's one of the downsides of the routine program data. And I will also speak to the systems that also the influence of the healthcare systems and information systems on the quality of routine program data that we all wish to be better. Next slide, please. So I would like to also touch base on some principles for accounting in this scenario that I'm presenting, vertical transmission. And I would like to just go through some recommendations also by WHO, what needs to be taken into account while measuring vertical transmission. So to ensure the accurate and effective measurement of vertical transmission, we must adhere to 4 key principles. So we need to account for the entire exposure period. So that means during delivery in antenatal care, but also postnatally throughout the breastfeeding period and after cessation of breastfeeding, and testing children after cessation of breastfeeding as it is recommended by WHO, especially in high prevalence settings, but also in populations at higher risk. We need to measure both vertical transmission rate and HIV-free survival for a comprehensive assessment. We measure vertical transmission at the population level, and that's the prerogative. So our data needs to be nationally representative at the population level. So this may be a model, it can be a study, but as I was saying, we normally look at all 3 data sources: data, survey studies, and program level data, if it's a good quality data. to understand the true impact and the measurement of vertical transmission, but also healthcare outcomes across different demographics. We consider the unique characteristics of prevention of vertical transmission programs, so meaning that multiple service delivery points need to be aligned, data systems need to be built in a way that the data is integrated across service delivery points, regardless of which service delivery point is being used. We also consider staff and capacity of the staff to carry on with the surveillance, HIV surveillance in comprehensive manner, as well as the health information systems that I will again touch base during the course of this presentation. Next slide, please. So this is the screenshot of the guidelines that we have on elimination of vertical transmission of HIV, syphilis, and hepatitis B. The requirement is that we need to make sure that the data meets certain standards, and that's the key in measuring health outcomes. Validation of elimination of vertical transmission builds upon existing protocols and tools. We need to adhere to WHO guidelines, again, to ensure a minimum standard is met for information systems and data quality. So I've highlighted which indicators are being used to evaluate elimination of mother-to-child transmission in countries, and this guidance recommends that we use population level estimates, meaning that the surveys or UNA spectrum estimates, or we triangulate both, as I was saying also, to see if the program meets the criteria for elimination or not. We also do use program level data in a range of countries, especially in countries with low prevalence settings where, and also something that I would like to highlight, and the concentrated epidemic settings where the epidemic is concentrated across specific demographics, such as people who inject drugs, or people who sell sex, or clients of people who sell sex, and gay men, let's say. So these populations are often marginalized or hard to reach. Surveillance across those key populations is another story that complicates the estimates, including in women and children and adolescents, because getting the records straight is not easy for such populations. And I will show the resources that you can also consult in measuring HIV, population sizes, and other data that goes into the models to measure health outcomes also in concentrated epidemic settings. Next slide, please. So also, that's another screenshot from the global guidance on validation of vertical transmission across 3 diseases as recommended by WHO. HIV transmission and case rates derived from studies or surveys. They also need to undergo some quality assessment. So something that we notice, for instance, from the presentation, as far as I remember from Botswana, is they mention that it is not easy to get the records straight for HIV prevalence in children, for instance, from the state surveys, depending on the sample size of those surveys. So a couple of things to just consider, that some surveys may not inform or answer the questions that the country has. And also the model estimates are complicated in low prevalence settings. And this is something that is highlighted in the text box on the bottom of the slide. Next slide, please. So how different methods for measuring vertical transmission or healthcare outcomes can complement each other. So that's the breakdown that I provide across models and surveys, but also across population program level data. You can look through those slides. We will share the slides after the sessions and also go through the examples that I'm providing on how to triangulate across those 3 data sources and approaches in measuring vertical transmission and health outcomes in HIV. Next slide, please, Ivy. So program data and special studies, routine data informs special study design, whereas special studies validate facility findings. So they speak to each other. Next slide, please. Special studies and models. Special studies enhance model accuracy. As I was saying, that we validate the estimates against the results of the surveys, and models inform the design and interpretation of the studies and the surveys as well. Next slide, please. So we are creating so-called feedback loops across those sources and approaches, and we make sure that the information system interact in a way that we can have some constructive feedback loops across the data sources that we have at hand for every specific country. Next slide, please. So the limitations are, and I've been already mentioning several, program data is only as reliable as its coverage. There may be gaps where we don't know who is missing from the data. It may be high levels of loss to follow up in women, but also in adolescents and in children. Silent transfers between health facilities. And in some countries, entire districts may be excluded due to lack of data or absence of services. Models also have limitations. Models become less reliable as numbers decrease, or if the program level data is limited or unreliable. So while the estimates in the hundreds of thousands may seem robust, distinguishing between small numbers may take a toll on the estimate. So the concentrated epidemic settings is even more difficult to assess than generalized epidemics. Next slide, please. So that's another screenshot that I wanted to provide from one of the, this is the 2022 SI guide, WHO guidance on strategic information. And something that I wanted to highlight is that there's a very complex interaction from preconception to pregnancy to labor and delivery, and especially postnatally, in just making sure that mother and baby pairs are tracked sufficiently and across service providers to make sure that our routine program data and case surveillance is correct across those many different types of service provision, but also then aggregated in a way that is consistent, and we don't see double counting or loss of certain populations. So that's a very important summary of monitoring tools and how to monitor PMTC cascade across a range of service delivery settings and providers. And here on this same slide, I wanted to highlight the importance of, and this is something Hewitt was speaking to also, the effective information systems that are crucial for strengthening health data on disease surveillance, health management, improving outcomes for diseases like HIV. That's also be a valuable resource in addressing the knowledge and status in not only in women and postnatally, but also in children. I provide some examples of health information systems such as EMR and HIS that also WHO and partners across the board
so just
support.
a
Thanks
quick
so
second.
much. While
Anna,
I understand that
yes,
I am
so
over time, and that's
yes, you
my
can round
last
up in
slide.
just 1 minute, and then we
Thanks,
have to
Wale.
move to the panel discussions. Thank you.
Thanks, Wale. Next slide, please. So the challenging, again, small sample sizes, key population, marginalized populations, and the challenges of measuring fertility outlined on this slide. Next slide. So these are the resources that I would invite the participants to go through, not only for the guidance, but also for measuring health outcomes at population levels. And thanks so much, and back to you, Wale.
Thank you. I think Mugaga, the chair, is here. We're really out of time, but Mugaga, please take over.
Okay, thank you very much. Just to take 1 minute to thank all our presenters, Heward, Stephen, George, Vanessa, and Anna. Thank you very much. And also to thank the audience that has kept the questions coming. Now I invite the next chair of the session, Ivy, whom I don't have to introduce, to take over the next part of the meeting. Thank you very much. Over to you, Ivy.
Thank you very much, Mugaga, for handing over the session to me. And greetings to everybody. We'll now proceed very rapidly into a panel discussion because we do have some more information that we'd like to share and discuss in the next few minutes. This is the panel. Unfortunately, the first panelist is not with us, but we have Dr. Alan, who is a medical doctor and the Associate Director for Technical Strategy at EGPAF. We have Dr. Ado and Dr. Farirai, who have already been introduced. We have Francoise Renaud, is a technical officer working with the Strategic Information Unit of the HIV, Hepatitis, and STIs Department at WHO headquarters. And we have Anna Yakusik, who has just made a presentation from UNAIDS. So I will lead the panel discussion in with a question to Dr. Alan Mai. Dr. Alan, what are your experiences developing and using innovative tools to collect data on advanced HIV disease in children and adolescents? And what would you suggest a national program should prioritize in order to improve data on AHD and AIDS-related mortality in children and adolescents? Over to you, Dr. Alan.
All right, thank you, Dr. Ivy, and I hope you can hear me well.
Yes,
Thank you very
go
much.
ahead.
And please allow me to maybe just quickly define advanced HIV disease, AHD, just in case some of the audience are not familiar. And in a summary, WHO defines advanced HIV disease as for adults, adolescents, and children more than 5 years old, as having a CD4 count of less than 200 cells per millimeter cubed, or having a WHO clinical stage 3 or 4 event. And for children, sorry, I was just looking at I saw a comment on my video. All right. So for children less than 5 years, then they are considered to have advanced HIV disease unless they've been on ART for more than 1 year and are clinically stable. So that's the definition of advanced HIV disease. And back to the question that you've asked me, Ivy. Yes, some of the innovative tools and approaches to advance HIV disease reporting. I'll acknowledge that advanced HIV disease reporting is quite complicated, and this is because of the long cascades of care. And for children and adolescents, this is a particular challenge because when the data elements that are needed to be collected are many, then it tends to, one of the solutions or the shortcuts that people take, and I'm saying shortcuts in quotes, is to reduce the disaggregation, right? And which is understandable because you want to make data collection simple. But once you reduce the disaggregation, then the biggest people or age groups who suffer are children and adolescents, because remember, they tend to be a smaller proportion compared to the adults. So if you don't disaggregate, And children, we know, are about 4% of all persons living with HIV who are on care. So if you don't disaggregate, then the 4% are really easily swallowed by the other 96%. So it's very key really to have the finer age disaggregations, and we saw the fine disaggregations that were provided by Dr. El Silasi, the 0 to 4, 5 to 9, and going all the way up to 24 years old. So it's very important for us to continue maintaining that disaggregation. We all acknowledge that reporting advanced HIV disease is complicated, and especially if this is being done with the paper-based tools. So some of the primary level or patient level tools that are needed for AHD reporting, this could be electronic medical records. You also remember that HIV-related data comes from other documents within a health facility. So this could be, for example, lab testing registers, inpatient registers, outpatient registers, immunization registers. We also have some countries who have adopted specific advanced HIV disease registers. So those tends to form our primary or source documents. In a lot of settings for AHD, these might not exist. From those primary source documents, we then tend to have a summary reports, which tend to be monthly. And again, some countries have this for the general HIV report, but this summary reports in many countries might also not include AHD indicators in general, but also specifically the disaggregation for children and adolescents that we mentioned earlier. So beyond the summary at facility level, then this tends to be cascaded to the subnational and national levels. And so some countries have repositories, while others might not have a repository for AHD data, as well as relevant analytics. I have a chart which I could have shown, but I think I'll just talk to it quickly and maybe demonstrate what's Kenya, for example, the Ministry of Health in Kenya have done. I know I work for EGPAF, but we also collaborate with the Ministry of Health, the NASCOP, alongside other partners in supporting AHD reporting. So what Kenya does is they rely for AHD reporting largely from the Kenya EMR, the electronic medical records. And this data, the EMR captures patient level service delivery aspects and the AHD related data. And then this data at the end of the month is uploaded electronically through a data warehouse application interface. And this goes to the national repository. And they are in the process, in the last 3 or 4 months, they have been developing the AHD dashboards based on that data uploaded to the national data warehouse. So what you notice that therefore Kenya does not have a physical or paper report to report AHD, but this is automatically done through the data which is uploaded from the Kenya EMR into the national data warehouse repository. And the overall coverage at this point is at about 90% of all the facilities that offer HIV services, that is care and treatment, are able to use the electronic EMR and upload their data monthly. So what are some of the recommendations that I might have to national programs to improve the AHD data and as well as AIDS-related mortality in children and adolescents? And first for me is really to adopt a standard AHD indicators for national reporting and tracking. I know we saw the 80 priority indicators that were listed earlier and the 25 core indicators. And I know as part of the global AIDS reporting to UNAIDS GAM, there are some AHD indicators which are reported as well. But if you've looked at the GAM reporting site, the Global AIDS Monitoring reporting to UNAIDS, you'll realize that a lot of the countries currently do not upload that data, the AHD specific data, be it for adults, be it for children and adolescents. So to me, I think one of the things we need to work on is ensuring that all countries really upload their AHD-related data to the global AIDS monitoring. And of course, that's at the top level. And for us to achieve that, we might need to adopt standard AHD indicators for national reporting and tracking. Not many countries currently have this. And I know as EGPAV, we've developed an AHD framework, which has these indicators. And in the last year, we've been working with ICAP, Sequin, EGPAV, and CHAI really to see how do we develop a toolkit that countries, the 21 countries within the ICAP Sequin Learning Network can utilize to form that primary AHD source tools. So secondly is to ensure.
Can we summarize? We have a few minutes to go,
Okay,
and
just
would
1
like to hear
minute.
from
Yes, so
others.
also to ensure that the primary source tools are in national use, and ensure that we build the capacity of the healthcare providers who will be summarizing and reporting this AHD data. So for me, if we are able to adopt those 3 or 4 recommendations I've spoken to, and especially use electronic tools, while acknowledging that electronic tools might have some challenges that need to be addressed, then that should help us obtain AHD-related data for children and adolescents. Thanks, and back to you, Ivy.
Thank you so much, Dr. Alan, for those wonderful insights. I'll just have another question for one of our panelists, and this is to Francoise. Francoise, are you with us? This question has come in from the Q&A platform. The multiplicity of indicators is interpreted at site level as an overload of work and sometimes impacts on data quality. But also the health information systems of certain countries is lagging behind on integrating HIV indicators. What is the best approach to maintain data quality in the face of the increasing number of indicators to be collected? But also, what could be the good way, a good way in which countries can be supported to integrate HIV indicators into the health information system to reduce manual and parallel data collection? So the question is really about integration of data and also data duplication. Over to you,
Yes.
Francoise.
Yes, thank you, Ivy, and thank you, everyone. Let me first introduce quickly myself. I work for the HIV hepatitis STI department in WHO, and actually my audio is linked to my phone. That's why you see me with my phone on my ear. And I'm leading the patient monitoring work in the department and working on the 2022 guidelines that HEWAT has produced together with the team. So I think HEWAT has already started to answer on the chat, Ivy, if you have seen it. So let me maybe step back before talking about integration. I think this webinar is really about joining forces to get better data for children and adolescents. And I would like to say that the 2022 SI guidelines that we have presented do not mean to be separate in terms of health information system, but it is to make sure that as you monitor HIV patients, including children and adolescents, you don't miss the key and priority indicators and the minimum data set that my colleague has presented earlier during the webinar. So it's about how the systems are built up in the countries and how best you can make sure that your HIV minimum data set and indicators are integrated within the larger health information system. Now, when it comes to prioritizing, you've seen that we have a set of priority indicators and core indicators, and you can start with these indicators especially if you use paper-based patient card and registers. For deduplication, you were asking, Ivy, I think the most important is, of course, the use of unique health identifier. But usually, you know, it's easy to say it. It's much more difficult to implement and to adopt at country level and to define the type of unique identifier. So it's something that needs to be addressed, I would say, at the level of the national HIV program, but sometimes beyond that, because it's across, it's not specific to HIV. You might have countries using an HIV patient identifier for the time being, but the goal is really to use electronic medical records and use a national health unique identifier across the board of the health system. I just want to make one point, is that the work that we have presented today in the first presentation, you know, we've shown tools that we are using to monitor patients, but also to improve the data quality. We have discussions with USAID and PEPFAR colleagues. This guidance will be made available in the COP planning guidance. So please use this opportunity, as you were also asking, you know, how to improve the system, how to improve the quality of the data. So please use the processes that are already established to integrate in your request, in your country plans, the use and the implementation of the guidance that WHO is making available to improve data. And you can specify, you know, for which populations you really want to use this tool. So you really have it from the planning processes. And also the Global Fund, you know, in their proposals for submission, we're working closely with them. So they also are very much supportive of patient monitoring, including in children and adolescents, and improving the quality of the data. So I think this is really very important, because it will help you also in the disaggregation work that has been highlighted across the board in the different presentations. This is also the topic to be highlighted maybe in the planning processes, to better disaggregate by age, by sex, so then you can improve your monitoring and your results and take the appropriate interventions to improve the HIV program management, but also the reporting. Over to you, Ivy.
Thank you so much, Françoise, for that very elaborate and succinct response. We only have time for one more question, and I hope Anna is still with us. The question is for you. Anna, are you here?
I'm here, Ivy.
Okay, yes. This is also a question from the Q&A platform. If you can just give us a quick pointer to this question. Children living with HIV estimates is the issue that most countries are grappling with. How can we improve our modeled estimates? And how do we address the issue when we notice that there are issues with global data? What channels are available from UNAIDS, WHO for reporting back any issues? Over to you, Anna.
Thanks, Ivy. And this is a really good question. And I've already provided my answer also in writing, but I think the underlying way of improving the data, and I think I will just also have to repeat a few ideas that Heward and Francoise just shared, we do need to have a really strong surveillance in countries in order to be able to inform the models with the relevant and solid and robust data from the program levels. And as such, it would be much more informative and robust the services and as well as the health information systems that we all, it looks like we are all striving to improve. So that's my response. Thanks.
Thank you very much, Anna, for that response. And unfortunately, we had a couple of more questions for our panelists, but we have run out of time. And yet we have one last exercise that we think is very important before we close this webinar. So before we move on to the next activity, I would like to thank our panelists for accepting our invitation to respond to some of our questions on this webinar and at this webinar. And thank you also for giving us very useful, important and practical responses. With that, I would like to thank all of you for attending this part of our webinar. And my previous co-chair summarized the first presentations. And before we leave, can we move on to the next slide? Before we leave, we would like to hear from you. We've come to the end of this year, but we would really like to hear from you what you would like us to, what topics you would like us to discuss in 2025. We would like these webinars to be driven by you, driven by demand, and we would not like to have, webinars that you do not find particularly useful or important to you. So we would like us to quickly, in the next 2-3 minutes, respond to this poll. What you need to do is either go to the chat, and our colleagues have posted the link for this poll in the chat. Click on the link and you'll be taken to a page that asks you to register or to skip. Please press skip for now and enter one word of a topic that you would like us to see, to deal with in 2025. Please use one word. And some of us have already started. Thank you. Alternatively, if the link is not working for you, you can use this QR code up in the top right-hand corner of the screen, and enter what you would like us to deal with in 2025. Mental health issues seems to be quite significant response, and I'm seeing loads and loads of responses. Please keep them coming in, and we will see how to summarize the issues that you would like us to address. I see EMTCT coming up. I see resistance coming up. Suppression, viral load suppression, I think that is. Yes, mental health seems to be getting bigger and bigger. Excellent. Keep them coming in. We will get all this data and summarize it and come up with a program for 2025. It's obvious that we will not be able to address each and every issue, but at least we can come up with an agenda that will be of interest to the majority. Thank you very much for participating in that poll. Aditi, can we have the screen back? The slides back? Okay. I see some of you posting some of the, okay, in the chat. It is okay. We will also gather information from the chat If the link is not working, please post in the chat as well. We'll gather that information as well. We'll be able to pick it up. So please go ahead, post in the chat if you've not been able to post on the poll. Okay. So wrapping this up, I'm seeing tracking patients. Thank you. So wrapping this webinar up, and once again, thanking our presenters and panelists, we have talked about data quality, the importance of having good quality data, right from the data, the frontline health worker, who is the beginning of the track of the data. So quality data in is quality data out. I hope that going forward, we have seen the importance of the front line, the first data entry, and how important it is. Whatever you enter, we know you're busy, but whatever you enter, it reflects at the end of the day and gives you information, very important information that will help you target appropriate interventions in an appropriate manner to the appropriate population. We hope to hear in the coming years of more and more country examples, facility examples, implementing partner examples of more and more innovative ways that will improve our quality of data. Next slide. So just to wrap up, this is our last webinar of the year. And this year we've been able to address a few of the priorities that were identified in the previous year. In our first webinar in June, we dealt with DTG resistance in children and adolescents. And it was one of those webinars where, you know, just after rolling out DTG, what are the experiences and the dealing with the fears that we are beginning to see DTG resistance in children. And we learned from that webinar that it is not yet need to worry, but we need to stay attentive and collect that data to make sure that we are able to learn more about the development of resistance. In August, we did not have a webinar, unfortunately, due to competing priorities and big conferences. And our next webinar we had was in October, where we dealt with indexing stigma, dealing with stigma from a lived sense, where we had excellent contributions and insights from different presenters who discussed with us the issues related to stigma from the lived sense, not just theoretically, but what they're going through and what they're living. And then our final webinar of this year has been this webinar where we've dealt with data and getting the numbers right. So with that, we have come to the end of 2024 with the webinar series of the year. And next year, we will be sending out the program. You will receive, as usual, the invites for the next year's webinars and when they will be starting. Next slide. We should be able to have our first webinar in February if all goes well. But again, you will receive the invitations as you usually do. So with this, I would like to give a special thanks to all the partners who have been involved not only in the preparation of this webinar, but all the webinars of 2024, all the speakers who have joined us and supported us through to provide quality sharing and quality information in these webinars, and all the moderators for the time and experiences they have shared. I would love to thank Pata, who have always provided us with quality interpretation services. I would like to also thank Echo India for and the Echo platform for granting us this beautiful platform on which we meet every 2 months, and always making sure that the webinars run smoothly with minimal technical interruptions. So with this, I would like to wish all of you happy holidays, a happy December, and a happy break for those of you who are taking a break. And final slide, I wish you all a very final slide. Final slide, please. I wish you all a very happy new year, 2025. We look forward to seeing you next year. Bye, everybody.
Thank you, Ivy. Goodbye. Goodbye. Goodbye.
Bye,
Thank
everybody.
you.
Thanks for joining.
Thank you,
Bye.
panelists. Yeah, it was wonderfully done.
Thanks and
Thank
bye.
you, Francois. Thank you, Wale. Goodbye, Hewat. Yeah.